Thank you so much for joining us today. We are happy to have Dr. Marc DiSabella with us today. He is the director of the headache program here at Children's National Hospital. We are going to have about a 50-minute or so presentation, and then at the end we will have time for some questions if anyone wants to do some follow-up. So again, thank you so much for joining us today, and we will get started.
Thank you, Melissa, and thanks everybody who's online and took their lunches to join today to hear about how to co-manage pediatric headaches. So again, I'm Marc DiSabella. I'm here at Children's National, and I direct the headache program in addition to the Child Neurology Fellowship program here. My disclosures are that I do receive support on the Zolmitriptan clinical trial, and we will mention its FDA-approved usage today. We won't be discussing Aimovig, the new CGRP drugs, today. So the objectives of the talk today are first to spend a good amount of time defining the characteristics of the primary headache disorders. And this is really at the core of the entire way to co-manage this, because without the correct diagnosis, we really can't move forward to how to manage these patients. After we discuss what the different primary headache disorders look like and sound like, we'll talk about the indications for ordering neuroimaging, which is the question that comes up with families, I think, most often. We'll move on from there to discussing the evidence behind different ways to manage headache disorders in pediatric and adolescent patients, followed by some explicit steps you can take as a primary care physician to co-manage headache with a neurologist. And finally, we'll discuss the recommendations for referral to our headache program at Children's National. So I've always learned you have to have something so everybody bites at the beginning of a lecture, and most of the time that hook is, I think, in headache, in that this is the most common disorder in the entire population from a neurologic standpoint. Everybody on this phone call has most likely experienced a headache at some point. The majority of all humans experience tension-type headaches throughout their life, and nearly a quarter of adolescents experience migraine without aura. So this peaks between about 15 and 25 years of age in females, and about 10 to 12% of males experience migraine between about 8 and 13 years of age. So these are very common disorders in pediatric populations. Unfortunately, about 1% of patients with migraine will experience more than 15 headaches per month, which is known as chronic migraine. And new daily persistent headache, which is a variant of migraine and tension-type headache, is seen in most reports in about 1% of the population, but in a recent study we published, 20% of the patients seen in our headache clinics had this headache disorder, which is a daily unremitting headache that's either migrainous or tension type for more than 3 months. Finally, medication overuse headache is also very frequent in the population, affecting nearly 2% of patients that use medications like ibuprofen, Tylenol, Triptans, or Excedrin between 10 and 15 times per month. On the right here, you can see some different graphs just showing the frequency. This top one is showing the frequency of all headaches in the population, but these peaks do have something to do with migraine. And this bottom one is just to exemplify that males actually have more migraine at a younger age, and they go away with puberty. Females start to experience migraine during puberty, and typically they wear off by their mid-20s in the majority. So as soon as you hear a patient presenting with headache, I think the first thing to always think about, is this a primary or a secondary headache disorder? So the primary headache disorders are the ones we're going to be focusing in on today, and this is migraine headache, tension headache, or the trigeminal autonomic cephalalgias, also known as the TACs. The one most people have heard of is cluster headache, but there's a variety of others in there, including the SUNCT, which is the short unilateral neuralgiform headache with conjunctival injection and tearing, paroxysmal hemicrania, hemicrania continuum, and some other subsets of those. But the key is figuring out who has secondary headaches. So who has a headache due to another disorder? And in the head, the only two pain-sensitive structures are the meninges and the blood vessels. So if it's a secondary headache disorder, it's something that is pushing on or infiltrating one of those areas. So brain tumors in and of themselves do not cause headaches unless they're attached to the meninges, press on the meninges, or press on a blood vessel. Alternatively, they can obstruct flow out of the entire cranium, and that may result in obstructive hydrocephalus, and that hydrocephalus results in headache. But brain tumor in and of themselves, we'll discuss later, are actually fairly unlikely to present with isolated headache. Meningitis, of course, can present this way. Hemorrhage in the head can irritate blood vessels and meninges. And finally, things like medication overuse can as well. So in order to determine which of these conditions we're talking about, primary or secondary, the temporal profile of the headaches is very helpful. So when you see the curves in the gray or blue fade here, those are the ones that we're most concerned about. So somebody with an acute, sudden onset of a severe headache is a headache condition concerning for acute obstructive hydrocephalus or a subarachnoid hemorrhage. So when you have a patient in the office that hasn't had headaches in the past, that suddenly is presenting with a brand new headache that is awful, usually associated with lighter sound sensitivity or vomiting, these are kids that we need to be sending to the ER. The second one is not a very concerning curve, and this is really the curve that you would see with tension-type headaches, migraine-type headaches, or the trigeminal autonomic cephalalgias. These are kids that have pain-free periods of time and then have sudden onset of headaches in between. In tension headache, they would be in the mild-moderate category. In migraine, they would be in the more severe, and the trigeminal autonomic cephalalgias are the most severe headache disorders. The third curve of a chronic progressive headache is the one that we worry about in slow progressive processes like a brain tumor that's slowly obstructing, in somebody with pseudotumor, and in somebody with medication overuse headache. But all of them have this progressive headache condition where each week or each month it's getting worse and worse. These last two are seen in other primary headache types, a chronic non-progressive headache. This is what a new daily persistent headache looks like. And the mixed headache is also what new daily persistent headaches look like as they have intermittent migraines on top of it. So again, when you hear about the headache history, you want to think about kids that have an acute onset of a terrible headache they've never had before, or kids that are experiencing increasing frequency and severity headaches over a period of time. And these are kids that we're worried may have a secondary problem, like tumor or hemorrhage. I want to spend a good amount of time today talking about the headache history. I always kind of take for granted how to take, I think we all take for granted how to take a history sometimes, but I want to talk about some of the pearls that I've realized over the last decade and some of the literature has as well. So it's really important to obtain an accurate headache history. So going into the fine details of what the headache is like is the only way to establish what the diagnosis is, which is the only way to establish what the treatment's going to be. I think it's really imperative to ask the patient, not the parent. So the first thing I do in every office visit, no matter where I am, is I arrange the seating so that the child's sitting directly adjacent to me and the parents are adjacent to the child. But me and the child can make eye contact, because otherwise most children or adolescents will look to their parents for their approval as they answer the questions. So I then explain to the parents it's very important that I ask the questions only to the child, and if the parents have anything to change, I'm going to give them an opportunity to after I take the history from the child. I'll say that children are excellent at doing this, and in fact, their histories are very to the point. They don't go off on digressions, and it's much more time efficient to ask the child. And most parents are very impressed at the end of it. It actually improves their relationship to the point that the parents say, you did a really great job. They usually compliment the child, and I got all the information I needed out of the right person in the room. Once you have this seating arrangement, you kind of explain everything, then really it's about establishing an accurate history. So start with the basic characteristics of pain. So every time you see a headache patient, you should always think about these 5 major areas: location, severity, quality, exacerbating or relieving factors, and associated symptoms. And these are the exact way I phrase these questions after years of saying all sorts of different things. So the first question I ask the child is point to where the pain hurts most. This is a very simple way of establishing the location, and it's going to help you differentiate a variety of headache types. Cluster or TACs versus migraine versus tension have different locations. Next is ask about severity, and here I ask about the range. Don't ask about the maximum. Everybody's had a very bad headache that you're going to see, and they're just going to say a high number like an 8, 9, or 10, and you need to know the range. So I usually explain this is a scale of 0 to 10, 0 being no pain and 10 being the most pain you can imagine. If the family seems like they're kind of playful or friendly enough that I usually say, so remember, that means being attacked by a cheetah on an exploding airplane is still a 10. You kind of get some laughs in the room for this, but it's trying to put into context that a 10 is supposed to be the most intense pain you can imagine, 0 is nothing at all. And then these ranges become more realistic, I find. Kids often will tell me they're between 2s and 7s, 2s and 8s. And that's the kind of number that helps you out understanding if it's mild, moderate, or severe. Next is asking quality. And I typically just say, what do your headaches feel like if you had to use a word to describe it? As soon as you start saying these example words, kids usually bite on the second or third one that they hear for some reason. So I usually try and say them pretty quickly so that they don't necessarily recognize all the words and just start to think honestly about what they mean. It's also helpful to describe what these words mean. Throbbing doesn't mean the same thing to everybody. So to say something that's throbbing, pounding, or pulsating, going boom, boom on your head, heart beating in your head, those types of words help understand what a throbbing characteristic is. Pressing, tightening, aching, these are all helpful words for the typical symptoms seen in tension-type headaches. Sharp and shooting and really intense are words people use around the quality of the TACs, or trigeminal autonomic cephalalgias. Next is ask what makes it better or worse. And the simplest way to ask this is, when you have a headache, do you want to move more or less, or it doesn't matter? If you could only ask headache patients one question, this is the one that differentiates all three of those headache disorders. Migraine patients want to move less. Tension headache patients don't care if they're moving or not. And trigeminal autonomic patients actually pace or become agitated and move more. So I'm not suggesting you shouldn't ask all these questions, but if you only had one question or what time to ask one question, this is the most specific question we're asking. Finally, after going through all of those features, which are actually the major criteria for migraine and tension type headaches, you then ask about the minor criteria, which is light and sound sensitivity, nausea, and vomiting. So do you prefer a dark and quiet space? Do you feel sick to your stomach? Do you vomit? Patients with TACs will have changes in one eye during the headache, like eye dripping or drooping. They get ptosis, mydriasis, in addition to conjunctival tearing or unilateral nasal congestion, sometimes even ipsilateral sweating of the face. So these are all the questions you're going to ask, and I would recommend framing them this way and asking the child themselves. So what I want to do now is go over some different histories, all of which fulfill the criteria for each condition. So these are all examples of patient with migraine. So on the right there, you can see the definition of a migraine. Major criteria is you have to have at least two of the following symptoms. If they're bifrontal or unilateral throbbing or pounding, moderate to severe intensity headaches that make you lay down. Minor criteria, you have to have one of them, light, sound sensitivity, nausea, or vomiting. So all 5 of these patients have migraine based on that definition. So a 16-year-old with bifrontal 5 out of 10 headache is now a frontal moderate intensity with preference to be in a dark room, just demonstrated light sensitivity. They just had 3 of those symptoms, they're migraine. A 5-year-old male who has headaches that are apical. Apical is still considered frontal in the world of headache. It's anything anterior to the ears. With a severe headache, so they've now had the location and the severity and they're vomiting. They just got 3 of them, they're migraine. A 4-year-old with unilateral throbbing headache, they already fulfill criteria now regardless of their intensity, and they're sound sensitive, they had 1 minor. I'd like to make a point though of this one. So an 8-year-old male with a frontal headache making him lie down in a dark room, even if he said the headache was a 1 out of 10, that is still a migraine. Migraine by definition is frontal, makes you want to lay down in the dark. That's 2 majors and 1 minor. So most patients with migraines get mild migraines and severe migraines. Migraines do not need to be severe by definition. So it's really important to recognize that so that you can use it to your advantage, because when you're talking about your migraine treatment plan as we get to that, that's not different for every headache. We're not going to use Motrin for mild ones and call them tension headaches. We're going to use Triptans or whatever our migraine plan is for all their headaches if they're migrainous. Finally, this last one, 17-year-old female with bitemporal throbbing headache with nausea, again, migraine. So I think everybody can understand these are the criteria. If you don't ask these 8 questions, you don't know what world you're in, so you really need to establish the diagnosis. And remember, you only need 2 of these characteristics. So a child with a 5 out of 10 headache that makes them lay down and they're sound sensitive has fulfilled the criteria for migraine. Now, I find when at least with my trainees in fellowship and residents, they oftentimes ask about aura before they've established the major and minor criteria for migraine. Aura is exciting and kind of sexy, so everybody asks about it. The reality is it doesn't really change a whole heck of a lot. So you're more than welcome to ask about it, and of course I'm interested in this. But it, again, does not change anything you're going to do. So about a third of patients with migraine experience aura. Of those patients, 70% of them experience visual phenomenon like bright spots, dark spots, squiggly lines, crescents, rainbows. 20% experience sensory symptoms like numbness and tingling that don't necessarily follow neurologic distributions. 9% of patients have speech changes like slurred speech or an expressive or receptive aphasia. And 1% of patients have more exciting auras like a brainstem aura or a hemiplegic aura. Brainstem aura is the current terminology for the prior known basilar type migraine, and that includes any aura symptoms that emanate from the brainstem. So think of all your cranial nerves, and here you get double vision, vertigo, altered consciousness, and tinnitus. Hemiplegic migraines are a very rare subtype of migraine, but again are associated with hemiplegia like a stroke, but by definition have to have at least 2 other aura symptoms, meaning vision or speech, before they started. So these are the different types of auras. Again, exciting and cool to think about, but really don't change a whole heck of a lot. Now, on the prescribing kind of notes for triptans and DHE or dihydroergotamine, it says do not use those agents in patients with hemiplegic migraine or certain types of migraine aura. The reality is that that's due to a historical component of how these drugs were created and has not been shown to be true in clinical practice. I'm not suggesting pediatricians should start giving triptans to patients with hemiplegic migraine. I would suggest leaving that to headache specialists or child neurologists that are more comfortable with this so that you don't impart further risk on your own practice. But when this has been looked at in actual retrospective reviews, there have been no increased risk of stroke in patients that have auras when they're given triptans or DHE. And in fact, they are the most likely patients to respond to them. So when I hear migraine aura, I think give a triptan immediately. That's who's going to respond. Now, oral contraceptives are actually something we all kind of say we should stay away from in patients with migraine with aura, and that is the recommendation of the CDC and the American College of OBGYN. However, to date, there is no clear evidence showing that that risk is in fact real. So we know that the risk of stroke is higher in patients on oral contraceptives, and based on one retrospective review, it showed that patients with migraine aura had an increased risk of stroke compared to the general population. So the CDC and American College of OBGYN have made the assumption that that combination will be synergistic and those patients will have an increased risk of stroke. When it's actually been looked at in a more rigorous scientific way, though, including this trial here on contraception 2016, there was no clear increased risk of stroke. So again, I'm not suggesting you should give OCPs to patients that have migraine with aura. However, the risks and benefits of that decision should be heavily weighed. If you have a patient who has severe cramping with their periods, or has a very high risk of becoming pregnant, and you think that risk is far more important than their potentially subtle increased risk of stroke, which we're talking about going from 0.1% maybe to 0.4%, you may decide to take that risk and in fact allow for them to have it. Again, you can also involve other pediatric specialists. Children's National has a pediatric OBGYN, Dr. Gomez-Lobo, who helps us with these decisions all the time, and you can consider referring to them as well. This is a tricky area. And then just to kind of finish on migraine, remember migraine has a lot of overlapping disorders. So on the left here, you can see the migraine precursors. So young children are much more likely to present first with colic is actually what research is showing as a migraine precursor. After colic, kids typically develop cyclic vomiting or abdominal migraine, and benign paroxysmal vertigo is in this group too. But these are all typically kids that are under 8 years of age or so. I don't truly believe in patients having cyclic vomiting starting in the teenage years. I think that's a different disorder, and that's probably a functional vomiting disorder. So this is migraine precursors. Then we move over to migraine without aura, which again of the migraine, this is going to be 70% of migraine. 30% of people have auras, which include the ones we just mentioned. And then 30% of patients with migraine have other vasomotor disorders, including orthostatic intolerance, syncope, and POTS, which are all pretty much the same thing. Depending on how you define them. So back to examples of kids that have one specific headache type. So we talked about migraine so far. So what are tension type headaches? So tension type headaches are much more diffuse or band-like headaches that are pressing or tightening, but they're specifically non-throbbing. So these are in the mild to moderate severity. They don't change with activity. You might be light or sound sensitive because who wants to be in loud rooms when they have headaches, but there is no nausea or vomiting. So if you had a 16-year-old female with a band-like headache that's 5 out of 10 and wants to be in a dark room, tension. 5-year-old male with diffuse mild headache distracted by play, tension. 12-year-old with bifrontal bioccipital aching headache with sound sensitivity, tension. And an 8-year-old male with frontal and occipital headache making him want to be in a quieter room, tension again. So you can see tension-type headaches and what they look like here. Tension-type headaches are the most common headache disorders in the population. They are less likely to present to medical attention, however, because we all experience these and realize that we just need rest or some more fluids to get better from them. Now, the thing we're worried about is increased intracranial pressure. And so here I wrote 3 examples of typical histories in patients with something more serious. So the first one is a 16-year-old female with a diffuse headache that wakes them from their sleep. It's constant. It varies between 3s and 7s all day. There's periodic vision loss, double vision, and pulsatile tinnitus that is synchronous with the heartbeat. And on exam, you see papilledema. This is a perfect history for somebody with pseudotumor cerebri. Next would be an 8-year-old male with a new onset headache for 1 month. It's daily and intermittent, but it's waking them up from sleep around the same time every night with vomiting. When you hear about headaches waking people up, not people that wake up with headaches, but people that have headaches that wake them up, I want your flags to be up. And again, we're going to talk about the indications for MRI soon, but this is one of them. On exam, this patient has ocular misalignment because they have a 6th nerve palsy from increased intracranial pressure and a bitemporal hemianopsia, meaning they can't see out to the sides of both eyes. That's what you see when you have compression of the optic chiasm medially. That's the history for a craniopharyngioma, which is pictured to the right here. Next would be a 4-year-old who's presenting with progressive headaches over the past 4 months, now becoming constant, associated with prominent spells of vomiting multiple times per hour for multiple hours. So excessive vomiting with a progressive headache. Remember back to our temporal profiles, this is that 3rd line down. This is the slope that was just going up at a nice even angle the whole way across. And that's the headache you want to hear, or that's the headache you don't want to hear about, but the one associated with a brain tumor or increased intracranial pressure. On exam, this patient has gait instability, and then, on history, and then on exam shows gait ataxia. This is a cerebellar tumor. In this case, thankfully, it was a juvenile pilocytic astrocytoma, which has an excellent post-surgical survival rate, more than 95% for over 5 years. So if you just wanted to take what the key factors in each piece of the history is and what the diagnoses are, if you hear about a frontal or unilateral headache that's worse with activity, that's almost always migraine. If you hear about a mild, diffuse, achy headache, almost always tension. I didn't talk a lot about clusters and the TACs because they just don't happen in kids very often. I had one of my first ones in years, and I've seen over 10,000 headache patients here in the last decade. So you don't need to be overly screening for these. These tend to happen in males in their 50s. If children are exposed to tobacco smoke a lot, they may have a higher risk for this. So if you hear about somebody with a severe periorbital headache that makes them agitated, think about the clusters and TACs and definitely refer on to me or the headache program here. We're more than happy to see these patients, in addition to all the ones we're mentioning here today. If you hear about a constant daily fluctuating headache associated with body pain, this is the typical story in the new daily persistent headache. Again, new daily persistent headache is somebody's phone needs to be muted, sorry. So this is the headache type of somebody with intermittent migraine or tension or no headaches in the past who suddenly gets a headache that's there every day all the time for at least 3 months and then satisfies tension or migraine criteria. Over time, they start developing body pain, which is called amplified musculoskeletal pain syndrome. Most of these also develop postural orthostatic tachycardia. We hear about somebody with headaches that are diffuse with vision changes at varying times, tinnitus and vertigo. This is the history of pseudotumor. And finally, if you hear about headaches waking a child up from sleep repeatedly, they have prominent and excessive vomiting, double vision, or balance problems, not lightheadedness, but truly ataxia balance problems. Worry about increased intracranial pressure. It might be due to tumor or obstruction, but these are all worrisome. And this is just a table for your reference to talk about headache history and each of the key factors. Again, if you just look at the site of the headache, this is really an easy way to differentiate. Migraine is either half of the head or the front of it. Tension headaches are everywhere. Clusters are around the eyeball. We didn't talk about trigeminal neuralgia, but as you probably remember from the past, this is a headache that's actually typically in the jaw distribution most likely. And these are really, really excruciating pain that happen, in my experience, hundreds of times per day when they touch their jaw. But again, a very different headache type. And I'm sorry, just let me go back. Duration is not something you need to worry about too much. So the duration of 4 to 72 hours is the adult criteria. That is not criteria for pediatric migraine. There's been debate for years at the American Headache Society and national meetings on this, and most pediatric headache specialists agree that migraines can be as short as 30 minutes, and in fact, some people suggest that they can be shorter than that. So the duration does not change how I think about these at all. So in terms of when you're thinking about your initial evaluation of a patient with headaches, Some of the common symptoms, intention headaches, again, they're all over the head. They're not worsened by activity. There's no nausea or vomiting. Migraine or moderate to severe intensity headaches across the front that make you want to lay down in the dark and the quiet. Maybe nausea and vomiting. That's more prominent in young patients than older. Migraine aura may occur right before the headaches or at onset and includes symptoms like vision changes, sensory changes, and speech changes most often. But also think about other common causes. In a pediatrician's office, there's quite a few patients I'm sure you're seeing that do not have migraine, tension, or TACs and have sinus headaches or allergic rhinitis or ophthalmologic problems or are depressed or have a head injury. So obviously screen for those things as you normally would. One note about sinus headache is just these are the most overdiagnosed condition, and probably the majority of patients that think they have sinus headaches in fact have migraine. This was proven to be true in the American Migraine Prevalence Study, which was several years ago. Over 150,000 households were surveyed for their headache types, and of the patients with migraine, 49% of them said they were sinus, and they were not in fact sinuses. Please remember also that sinus headaches tend to be in the maxillary region below the eyes, not above the eyes, and in fact the frontal sinus does not completely form until you're a bit older. So headaches over the eyes are unlikely to be sinus related in patients that are young. So who needs imaging? And the good news about this is almost no one. So all of the data on this shows that patients with abnormal exams need imaging, and there's no historical factors that ever override or force you to do that. So first off is a quote from one of my favorite movies, Kindergarten Cop, and it's not a tumor. But I reassure families and talk about tumors a lot at visits. First off, pediatric brain tumors are infrequent. They occur in about 3 to 5 patients per 100,000. So that means less than 1 brain tumor for every 50,000 patients presenting with headache. So there's a very good chance that in your practice you have seen 50,000 patients, none of which had a brain tumor. So good news. Brain tumor is not likely to present with isolated headache. It's more likely to present with other symptoms involving where it was. So about 60 to 70% of pediatric brain tumors are in the cerebellum or posterior fossa and are much more likely to present with ataxia, double vision due to increased intracranial pressure, weakness, speech changes, visual field deficits. So again, probably not just headache. In our headache clinics here at Children's in the last 5 years, we have had, I believe it's still less than 5 patients that had brain tumors that we did not know about beforehand. So tumors only cause headache if they obstruct CSF outflow from the brain or they compress the meninges. So again, it's unlikely to be the only symptom. And there is risk in ordering imaging. 20% of patients that are pediatric that get an MRI will have some finding. T2 hyperintensities, an empty cell tersica, an arachnoid cyst, and you've now increased the anxiety of the family rather than taking it away because you found an incidental finding that's a Pandora's box that everyone is going to chase for a while. So I would suggest trying to be careful about who you order MRIs on, and I don't think there's an indication for CAT scans except in emergencies. So here's what the data shows. So this is actually a meta-analysis of all of the series looking at pediatric headache and MRI findings. So 605 children were studied amongst these 6 studies. And of those, only 2.3% or 14 of them had relevant space-occupying lesions, meaning incidental findings are thrown out here, but who has something in their brain that has to have an operation or something done surgically. So 14 of them. Every one of those 14 children had abnormal neurologic exams. So a sufficient neurologic exam is sufficient to take away or add in the need for an MRI. So it's all about the exam, and we'll talk about what that exam looks like in a couple minutes. This is the study that found all the tumors. So of all those studies in the meta-analysis, the Medina study from 1997 is where the majority of those were. These are 315 children who had MRIs. These are between 3 and 20 years of age. They all had headaches. 28% of them had something abnormal on their exam. And you could argue only those 28% should in fact be imaged based on what this study proved, which is only 13 of those 315 children had anything that was a surgical space-occupying lesion, meaning a malignant neoplasm, a vascular malformation, in one case an arachnoid cyst that needed an operation. But every one of those kids had an abnormal exam, so it's all about the exam. Now there were historical factors that they found in this study that had a higher risk for intracranial lesions, and they're listed here. But again, I want you to come away from this remembering that patients with a recurrent headache and a normal neurologic exam generally do not require additional testing that includes labs. Brain imaging, though, should be considered for patients who have headaches that aren't responding to standard treatment and they're fairly new. Headaches with an abnormal neurologic exam finding, especially papilledema, nystagmus, gait, or motor changes, is an absolute indication for an image. Other things found in this Medina study was an absent family history of any headache type, so no first-degree relatives had any headaches. A headache associated with substantial confusion or emesis. Substantial, again, we're talking about true encephalopathy, kids that can't remember their name, they don't know where their bedroom is, it's not that they can't concentrate. And substantial emesis is more than 4 episodes of emesis per hour for multiple hours in a row. Headaches that awaken a child from sleep repeatedly. Not that your headache woke you up last night, your headache has woken you up every night for the last 2 weeks or 4 weeks or 4 months. That's the one I worry about. And then finally, a family history of disorders that predispose children to central nervous system lesions such as brain tumors or multiple cerebral brain aneurysms. So unfortunately, 4% of the population has a brain aneurysm, which means that hearing about a relative who had a single aneurysm that ruptured is not, in fact, indicative of a genetic predisposition towards that. But multiple aneurysms is, because now we're talking about genes like the polycystic kidney genes, which carry with it risk for aneurysms. So if you hear one of these historical factors and you see an abnormal exam, that is an absolute imaging case. If you don't hear any of these historical features and you find something abnormal on exam, you should still absolutely image that patient. If, however, you have a completely normal neurologic exam and you hear one of these historical factors, you may order an exam, and in fact, insurance companies are looking for these terms. So they're going to pay for it usually if you see one of these things. But you can reassure the family that in the setting of a normal exam, it is very unlikely the child's going to have something more serious. Finally, as pediatricians, you're obviously going to be testing for other systemic diseases when you suspect them. So a child who had a tick bite with a bullseye rash, who has joint pain and a headache now, you're sending off your Lyme Western blot. So you'll obviously use your common sense and medical skills in order to sort out who needs those. So what is the basic treatment that should be recommended for all the primary headache disorders? And each of them is shown here, and this has not changed significantly over the last several years, but we now have great evidence to prove that hydration, exercise, sleep, and diet are really the controlling factors for pediatric headache. So I just really briefly want to talk about why headaches hurt. And pathophysiology of migraine you could replace here with tension-type headache. There's a lot of similarities with those TACs as well. So really what happens underneath is step 1 here. There's some sort of metabolic activity that's increased in the environment. So migraine and headaches are essentially a mismatch in the amount of energy available and the amount you are using. And if you talk to anybody with migraines, they'll agree to this. They say, you know what? I didn't sleep that well. I had a big test and I skipped breakfast, and that's why I got my headache, I think, today. So all of these things put metabolic stress into the system. Then there's activation of a nucleus in the brainstem that controls the trigeminal nerve, which is the one that gives us sensation to our face. There's actually depression or spreading cortical depolarization starting in the back of the brain and moving forward, which explains why visual auras in the visual cortex are the most common, followed by sensory, speech, and motor, because you're really just watching this wave climb forward, and most of the time it doesn't get past the occipital lobe. And finally, there's some reason that blood vessels stretch out in the brain, and those stretching blood vessels actually stretch out the trigeminal nerve, which then gives you the pain typically in the front of the head or around the eye. So I think it's important to explain that to families because that's going to help with your buy-in on terms of what they need to do. So after this lecture, we're going to be sharing the slides, and we're also going to come up with a way to have this headache treatment plan listed for pediatricians to use. But we use a specific headache treatment plan for every patient we see that includes a fluid, exercise, sleep, and diet goal. We have been studying screens, so we talk about those a bit. We talk about some behavioral practices, including it's okay to participate, and in fact, we encourage kids to participate despite their headaches so that they are distracted, which actually teaches their brain to ignore the signals more and more. We instruct parents not to ask or check in about pain. This is a huge part, and finally the kid wins and kind of looks back at his parent and winks because he knows that his parent's been asking him a lot about how is it now, how is it now, how is it now. And all qualitative subjective symptoms in our body are amplified by asking about them. If you had a rash right now and I said that looks really itchy, it sure would be. So tell parents not to check in about their headaches. We don't need this to have a really exquisite, detailed diary about how frequently it's happening. It doesn't change my management much at all. I really want to know gut instinct. Do you have a headache every day? Do you have them half of the week? Do you have them half of the month? I mean, those numbers are enough to figure out what you need to do for your next steps. We're going to talk about the use of preventatives like riboflavin and others. Next on the treatment plan is our rescue plan, and everybody should have a rescue plan. We also list here about infusions in case children have status migrainosus or long headaches, and then we talk about testing. But the bulk of your treatment plan is the lifestyle techniques or preventative treatment on the top, in addition to behavioral treatment. Everyone should have a rescue. Very few people actually need preventatives. So this is how we explain migraine to families. So first we talk about the criteria for migraine, or you can again replace that with tension headache or whatever one you're talking about. But I specifically show them those charts I just showed you with the 8 blocks and explain the criteria why your child has this. It's really important that you substantiate the evidence for why the child has this disorder, because otherwise parents want to know what is it, but you didn't explain what it is. Why is this organic? So it's important to explain migraine is a real thing. It's the most common thing causing headaches in pediatric patients. It affects a quarter of girls between 15 and 25. It happens because of metabolic derangements that result in this energy mismatch. And all those things I think are important because you need them to buy in so that they can do what they need, which is lifestyle modification, behavioral strategies, and abortive therapies. So again, we talk about all of these pieces. We've kind of walked through 1, 2, and 3. We talk about the indications for diagnostic testing. I specifically spell out those criteria we just talked about from the Medina study, and I say here's why your child did or didn't fulfill them, and here's why we need an MRI or not. Still, the most common reason we order MRIs is parental anxiety, and I explain to families why I think it's going to be normal. If a family says they still want it, I explain that if an insurance company denies it, there's not much we can do if there is no evidence for us ordering them. It's always okay to punt this also over to your neurologist or the headache program here at Children's. Finally, we talk about contact information for interim support. We have a headache nurse in our program that is constantly on the phone talking to these headache patients, helping them get through their day-to-day life. We talk about emergency protocols and specific follow-up. So when you look at the goals of migraine treatment, we want to reduce disability, we want to improve quality of life, reduce the progression of the disease, and develop adaptive pain coping strategies. So at your first visit, I would recommend always telling everyone about hydration goals. Specifically, I tell them the goal of ounces per day is their weight in pounds. We cap it about 100 ounces. So if you have a 200-pound kid, it's still 100 ounces, but a 50-pound kid is 50 ounces, a 70-pound kid is 70 ounces. It's roughly 2 times maintenance. We then explain not using any caffeine or artificial sweeteners. So caffeine and artificial sweeteners are both vasoactive, and migraine is a vasogenic disorder. So we don't want to mess with the vessels. They're already messed up. Caffeine, when you take it in, actually causes some improvement in headache because it increases oxygen flow to the brain and can reduce headache. That being said, everyone withdraws from caffeine. There's no such thing as someone that doesn't. So you can't continuously infuse it, and every time you use caffeine for a headache, you are going to get another one. The most common reason for headaches in my clinic is caffeine overuse or caffeine use at all. We instruct everyone to stay away from these, and there's been multiple trials showing this is the most effective way to treat headache. Next, after hydration, is an exercise goal. This can be anywhere between 5 and 7 days a week for 30 to 60 minutes at a time. We talk about the fact that this is cardio. So I typically explain what cardio means, and I explain that is not walking to school, that is not walking up the steps at school. This means that you are huffing and puffing. You can't say a complete sentence. Talk about sleep guidelines. So it's 8 to 12 hours based on the AAP or sleep guideline recommendations, but variability is really important. Patients that stay up or sleep in more than 2 hours later on weekends have increasing risk of headaches when they go back to normal time. In other words, kids that stay up late all weekend get headaches on Mondays and Tuesdays. So we highly suggest against sleep shifting on weekends. Finally, if your belly's starving, your brain is definitely starving, and this is an energy disorder. So eating 3 healthy meals per day plus snacks is really important to this as well. I realize as a pediatrician, most of you have 15 minutes or less for your appointments, and this takes a lot of time to review and re-review and reassess at each visit, and that's why we're here at Children's Headache Program. We see headaches that are very simple and respond to lifestyle modification. We see the most complex headache patients with brain tumors and intractable disease. But that's why these resources are available to you, so feel free to use our clinics. We're not just designed for patients with the worst headaches. We're designed to help with any headaches, especially if your practice can't handle the education of it. Moving on from lifestyle, every child should be given an abortive or rescue medicine. Typically recommend ibuprofen at 10 milligrams per kilo, maximum 3 days in a week to avoid medication overuse. Medication overuse is defined as more than 15 doses of any NSAID or analgesic combined for 3 consecutive months. So a child that takes 8 ibuprofen days a month and 7 Tylenol days a month has just broken the 15-day rule. They're at risk for medication overuse. So don't alternate, pick one, stick with it, and keep count of it. Anytime they take a rescue medicine, we recommend they drink a fluid bolus with it. Specifically, we recommend sports drinks, and you want the high-calorie ones. You don't want G2, Propel, or Frost. You want Gatorade or Powerade, 160 to 180 calories per serving. The reason is that high fructose corn syrup specifically is a very easy energy source for neurons. Neurons respond to this, and there's data ranging from neonates to adults showing that pain scores decrease by an average of 2 points when given high fructose corn syrup. For anyone that rounds in nurseries or NICUs, you know about Sweeties, those little coffee creamer-looking things on all the counters next to the newborn beds. They put pacifiers in them before we do painful procedures like IVs or lines or taps on kids. That's because high fructose corn syrup, which is what is in Sweeties, reduces their pain. In patients with obesity or diabetes, obviously you're going to weigh this with the risks, but most of the time we're recommending this. And finally, triptans like sumatriptan, almotriptan, rizatriptan can be considered up to twice weekly if there's no contraindication. So I just briefly want to talk about the evidence for these treatments. So ibuprofen has the best evidence. There is no established superiority, however, to doses over 400 milligrams, definitely none over 600 milligrams. So prescribing those 800s don't really change the outcome for any of those patients. So I cap at 4 or 6. If you give them early, they seem like they work better. It's important they don't use them more than 3 days in a week, and it is superior to Tylenol twofold after 2 hours. Tylenol can be used at 15 milligrams per kilo up to 3 days per week. It's superior to ibuprofen at 1 hour, but then becomes reduced in its efficacy thereafter. And naproxen, which is Aleve, is also 15 milligrams per kilogram, the same as Tylenol, so don't underdose it. That means most patients are going to take 440 or 660, which means 3 Aleve. Don't use them more than 3 days in a week. There's no randomized evidence. There's no randomized controlled evidence for this as monotherapy, but the combination with sumatriptan is effective, and empirically I've seen naproxen be very effective for patients. In terms of triptans, these are the 8 triptans that we can prescribe, 7 triptans we can prescribe, and I just want you to pay attention to the red over here. So randomized controlled trial has shown no efficacy in the majority of these agents, including oral sumatriptan. So Imitrex tablets have never been shown to be effective despite 3 randomized controlled trials looking at it. So I do not prescribe this medication at all. Thankfully, insurance companies have come around to this and no longer are requiring that you start with Imitrex. If you do want to use it, the nasal spray has been shown to be effective and comes in 5 and 10 milligram doses. Aside from that, zolmitriptan, or Zomig, is effective in both a tablet and nasal form. Almotriptan, or Axert, is effective in a tablet form. And rizatriptan, or Maxalt, is effective in a tablet form. Of the tablets, there are melting tablets and swallowable tablets. The swallowable tablets work faster and are more effective than the dissolving ones, even though that is counterintuitive. But it's just the way it works. So I think this is, to me, the most important slide and the most important headache study that's ever come out. So the NIH published the CHAMP study in 2017 in the New England Journal of Medicine. And what this trial looked at was patients between 7 and 17 years of age were randomized to have lifestyle modification, the hydration, exercise, sleep, and diet goals I shared with you earlier. They were randomized to do that for 1 month, and after 1 month were given either placebo, amitriptyline at 1 milligram per kilogram, and topiramate at 2 milligrams per kilogram. At the end of the 24-week trial, there was no difference between the 3 groups. Amitriptyline and Topamax were no more effective than placebo at the end of this trial. So this is a very fascinating study and taught us a lot about headache. But during the initial period where patients were instructed on hydration, exercise, sleep, and diet, no patients had a significant improvement in their headaches. So lifestyle modification in and of itself did not improve their headaches. However, almost 70% of patients had half as many headaches after 1 month on placebo. So 2 months into the trial, they've been drinking a lot for a month, and now they're on a placebo for a month. 70% of them are better already. So you can cure 70% of your headache patients by doing lifestyle modification and a pill. But if you don't give them a placebo, nothing will work. So rather than give a placebo, I would recommend giving either riboflavin or coenzyme Q10. Both of these agents have randomized controlled data to suggest that they are more effective than placebo. In fact, 75% effective. That's better than amitriptyline and Topamax. They are cheap. They are available on Amazon and at Target and at CVS for CoQ. Riboflavin's just on Amazon. but 100 milligrams twice daily. Very few, if any, side effects. Riboflavin makes you have orange pee. CoQ might give you an upset stomach. But these work well, and you need a pill to get better. So I have patients on these for a very long period of time with absolutely no risk. But again, lifestyle doesn't work without that. The psychologic expectation that the pill is going to help is just as important as its biologic effect. So I wanted to be explicit about what you can do as a primary care provider to manage headache. So again, ask targeted headache questions to determine the diagnosis. Where is it? What does it feel like? How bad is it? What are the associated symptoms? And what does activity do to it? Perform a thorough neurologic exam, including a fundoscopic exam. So I want to stop there. If you cannot see the fundi, it's okay. I don't think most people can see the fundi when they're looking. But if you can't, your exam, in fact, is not the thorough one that can exclude a brain tumor, and that's a reason to have somebody else look. It's okay to refer to an ophtho or to a neuro person because you couldn't see the discs and you're worried. Or it's okay to say, you know what, I'm going to use those historical criteria there, like headache waking them out of sleep, because I can't, in fact, assure that the exam is completely normal. Otherwise, you're looking for abnormalities in extraocular movements, your pupillary exam, visual fields, facial sensation, muscle strength and tone, reflexes, finger, nose, finger, and gait. These are the big areas that are going to predict who has tumors. Instruct all patients on lifestyle modification, including hydration, exercise, sleep, and diet, and give them something. You can give them amitriptyline or Topamax, but I would highly suggest a nutraceutical like riboflavin or CoQ. There is no randomized controlled evidence showing that magnesium is more effective than placebo. In fact, there's evidence to the contrary. Placebo also beat magnesium in the RCTs I'm aware of, and 20% of patients on magnesium experience sleepiness, depressed reflexes, and have GI cramping and diarrhea. Number 4, provide a rescue plan for everyone, including their rescue medication and a sports drink if they can have it. Ibuprofen 10 per kilo. Don't use it more than 3 days a week. Cap it around 600 or 400 milligrams. You can provide a Triptan if you feel like it's migrainous and you want to go into this territory. The ones that work, nasal sumatriptan, nasal zolmitriptan, and oral zomatriptan, rizatriptan, and almotriptan, which again is Zomig, Maxalt, and Axert. And again, don't use it more than 2 days a week. If you give a rescue, tell them how to not overuse it. Provide specific follow-up timing, typically 2 to 4 months, and also provide school medication forms. These meds don't work if they don't have them. Triptans specifically don't work outside of the first hour of headache. So if it's not at school, they might as well not bother. So in terms of referral, so when you have patients that you don't have the time to make better because it takes a lot of time, when you have patients that you can't do a good exam on, when you have patients that have a lot going on in other parts, feel free to refer them on to our headache program. If somebody has a really horrible, severe headache out of nowhere and they have a neurologic exam that's abnormal or papilledema, you don't need to send them to me, send them to the ER. That's a scary story. But all those other kids that are just difficult and not getting better, feel free to refer them in. If they come with a headache calendar or a list of medications or labs or imaging, I'm more than happy to review those. It's not imperative, and we're happy to see patients and get them better. So again, we have a pretty large headache program. After the recent American Headache Society, we may have the largest headache program in the country at this point. It's unclear to say, and people aren't kind of giving out all that information. But we have currently 5 attending physicians, all of whom see headache, 1 nurse practitioner, and we have some weeks up to 100 urgent access appointments. We're seeing patients in Annapolis, Washington, D.C., Fairfax, Frederick, Friendship Heights, Laurel, and Rockville, so an entire circle around the D.C. metro area. Additionally, we have an even larger comprehensive headache team, including behavioral pain medicine, psychologists. We have anesthesiologists that do trigger points and nerve blocks. We have physical therapists that do desensitization and pain deamplification. We have a neurosurgeon who does outstanding things for patients that need neurosurgical intervention. There's a coordinator for the clinic that answers the phone every time you call our headache number. We have a headache nurse that answers all of the patient phone calls in between, writes IEPs for patients, does authorizations, sends in their school forms. We have an outpatient infusion center in Washington, D.C. We have another one in Fairfax, Virginia. And we have a research assistant with lots of things going on right now. And in fact, those numbers are wrong because we have more protocols and more clinical trials. So in conclusion, classify the headaches based on standard pain questions. Instruct all patients on healthy habits, including hydration, exercise, sleep, and diet. Minimize your testing and medications and over-medicalization. Provide every patient a rescue plan, and keep trying, be patient, and listen to your patient about their needs. So thank you very much for the time. Thanks for your interest in calling in today, and thanks for all the referrals to the headache program at Children's.
Thank you so much. I really appreciate you joining us today, Dr. DiSabella. If anyone has any questions, please go ahead and you can ask them now. We do have another few minutes still. You can also type them into the chat box as well. You will be receiving an email regarding claiming your CME credits. You do have 90 days to do so from today. So we will be, like I said, sending you an email regarding that, as well as posting this presentation and some additional resources and guidelines online for you. If you have any questions, you're welcome to email me regarding CME. I'm going to put my email address in the chat section for you.
I don't see any typed questions. I hope I'm not missing them. If anybody does have questions and they want to unmute, you're more than welcome to ask.
I just had a question about post-concussive headaches. How long do you typically tell people to refrain from doing like physical activity or anything like that?
Yeah.
The guidelines recently changed.
Right, yeah, so it appears that early activation has the best outcomes. So 2 to 5 days is an absolute maximum for me for rest and return to school. I typically like kids moving again within 2 days and back to school within 5 days. But there's some very clear data that those are the kids that get better the quickest and have the best outcomes. So we don't have to cave to saying you shouldn't do anything. Now, I'm not suggesting they're back on a football field banging their head again, but kids that are aerobically starting to reactivate as soon as possible after the injury seem to have the best outcomes. So I have them starting off with things like yoga and stretching and moving to walks around the neighborhood with a dog, moving into kind of a light jog or riding their bike, and then getting slowly back in until they can do 30 minutes of intense aerobic activity without symptoms of their concussion.
Dr. DiSabella, we do have one question. Is there an indication for Botox for migraine in adolescents?
I just did a Botox this morning on a patient. So the correct answer is no. So the only randomized controlled evidence for Botox in pediatrics showed no superiority to placebo. So patients were injected 31 times with saline or Botox, and there was no difference between those groups. That being said, there are patients with intractable and very, very difficult to treat disease, or they can't sustain additional side effects from other medicines. So this morning, I was able to see a patient with very advanced cancer throughout their brain and spinal cord who has intractable pain, who we need to be very careful about what we use. Botox actually has a very nice safety protocol or profile to it. So Botox can be used, but Does it actually work? I'll say from my personal experience participating in a clinical trial on this in Cincinnati, I'm very suspicious that it's better than placebo, and it's 31 injections every 3 months. Even the best data on adults, which is called the Preempt 1 and 2 trial, only showed an average of about 6 headache day reductions in patients that had a mean of 28 headache days per month. So it's basically patients with daily headaches get about a week off of their headaches with Botox, but there was no improvement in quality of life or severity in that trial. So again, I don't think it's as exciting as we would think. The newest category of drugs on the market are called CGRP antagonists, which are calcitonin gene-related peptide antagonists. We will be participating in a clinical trial on this in the coming months once the contracts are finalized, but that's going to be from 6 to 17 years of age, doing once monthly subcutaneous injections using these agents, which have, again, it looks like the safest safety profile out there. So we're hopeful that they're going to be efficacious in kids as they have been shown to be in adults.
Great question. All right. It doesn't look like we have any other questions in the chat. Thank you, everyone, so much for joining us today. We really appreciate you spending that past hour with us. We hope you gained something from it. Again, we will post resources for you online, and we will send you a follow-up email regarding this information and the CME credits. So thank you so much for attending, and we hope you can join us at a future Lunch and Learn. Have a great day.
Thank you, everyone. Bye-bye.